So let's talk a little bit about withdrawal in med-surg patients and how to assess the risk of withdrawal. And I might have just stolen my own thunder. So here's a question. A male patient was hospitalized yesterday after an automobile accident for the treatment of a pelvic fracture. This morning, he began showing signs of alcohol withdrawal. What is the preferred medication for treating alcohol withdrawal in the med-surg patient? Is it A, chlordiazepoxide or Librium, B, lorazepam, C, gabapentin, D, phenobarbital, or E, diazepam? And the answer is B, lorazepam. So in the presence of medical comorbidities, certainly using shorter acting drugs such as oxazepam or lorazepam that undergo extrahepatic metabolism are ideally preferred. Anticonvulsants as a whole have not been proven to be any better than benzodiazepines. They can be considered in mild withdrawal states due to their advantages of low sedation and lower chances of dependence or abuse potential. However, they may not have the expected advantage of preventing seizures or DTs in alcohol withdrawal states, and therefore their use is not recommended in severe withdrawal states. So, using anticonvulsants alone, kind of iffy. Is adjuvant and to help the withdrawal process be smoother? Absolutely. So we know that chronic alcoholics account for anywhere between 30 to 70% of med-surg patients, of 70% of patients with head and neck cancer, and to 50 to 60% of the patients that are admitted for trauma. So again, needless to say, it's extremely important that we assess for alcohol withdrawal risk because many of these patients are admitted acutely. Many of these patients are, stay inpatient for more than 48 hours. And we have a lot of, challenges because many of these patients are treated with opioids, sedatives, and anesthetics that can mask early signs of withdrawal. One big one that's always worth, being mindful of is not forgetting that beta blockers can also mask withdrawal. And so here we are thinking, monitoring somebody's vital signs and thinking that they're doing fine. And that beta blocker didn't let us realize that the hypertension, or the tremulousness or the tachycardia were happening behind the scenes. So, back to, thinking about using, screening tools, certainly nothing should ever replace a good, patient-doctor, interview and getting, good collateral information. But the cage for screening at a minimum, or at least the tweak questionnaire, which is more sensitive than the cage, it can be used as a tool to, to find out how much somebody is using, how often, and for how long. So we know that overall, again, nothing is 100% set in stone, but overall, withdrawal symptoms are associated with anybody that's consuming more than 5 to 6 drinks a day, which is the equivalent of more than 80 grams of alcohol per day for a prolonged period of time. It's more common to see patients have withdrawal symptoms if they're over the age of 30, but I'd be lying if I told you that I haven't seen patients much younger than that are heavy drinkers that develop alcohol withdrawal symptoms themselves. So do not be misled by somebody's age in front of you. DTs, which is alcohol withdrawal delirium, and I clarified the terminology because I don't know if the board will use the terminology delirium tremens or DTs, or if they want, or they will use the terminology alcohol withdrawal delirium. But it usually happens with people that consume 16 or more drinks a day for several months. And certainly the concept of kindling, is important in the world of alcoholism, which is a concept that we've borrowed from our colleagues in neurology, where, the more seizures you have, the more prone you are to having, more seizures downstream, the more severe the seizure may be, and the more likely you are to have it even at, at a lower threshold. So when assessing some of these patients, certainly the more times that you've gone into detox, the more you've exposed your brain to withdrawal, or the more someone has had a history of seizures, the higher the likelihood that they'll probably have one in this subsequent episodes. So the tweak questionnaire, which again is very straightforward and simple to use, assesses tolerance and how many drinks does somebody consume and can you hold. It assesses a concern about worried about your use. It asks about eye openers, so very similar to the cage questionnaire there. But it also asks about amnesia, what the cage doesn't, and amnestic episodes from drinking, and again, but it does ask about the cut down, which is similar to the cage. Adding up the points, if you have a tweak score that's lower than 3, you're probably at low risk, for dependence and subsequently at risk for withdrawal. But if you have a score that's 3 or greater and you're somebody that's greater than 30, you have more than 4 to 5 drinks a day, you have had alcohol withdrawal, seizures, or delirium in the past, and your last drink was definitely less than 3 to 4 days ago, that puts you into a different risk category. So again, we've talked about that the underlying mechanisms of alcohol withdrawal are certainly decreased GABAergic activity and increased glutamatergic activity, coupled with probably upregulation of calcium channel activity and probably some increased noradrenergic activity. But at the end of the day, it's the primary mechanism of action that happens in withdrawal is that increased glutamatergic activity. So signs of alcohol withdrawal. Again, some of the autonomic hyperactivity and some of those symptoms can start as early as 6 hours after somebody's last drink, and they can peak 24 to 48 hours later. And they'll be characterized by, tremulousness, diaphoresis, anxiety, nausea, vomiting, hypertension, and the like. If hallucinations start to happen, more often than not, they are visual. And the neuronal excitation, i.e. seizures, can happen most commonly within the first 12 to 24 or 48 hours after somebody's last drink. So the overall goal in alcohol withdrawal treatment is to substitute a cross-dependent drug, in this case a benzodiazepine, to help with the withdrawal process. Since we can't admit somebody into a hospital and give them, that's consuming 10 beers a day and then gradually do a taper to 9 beers, 8, 7, 6, 5, 4, 3, 2, 1, the best that we can do is to trick the brain into trick the brain into thinking that it's receiving something similar that's cross-dependent and gradually withdraw with that substituted drug. And again, depending on where you work or depending on where you look in the literature, there's different benzodiazepines that you can use, and there's different indications for each. It's really important to supplement with things like thiamine, folic acid in the course of treatment. Probably the most important thing that you want to do in order to minimize the development of Wernicke's encephalopathy is to make sure that you administer thiamine immediately, either IV or IM, to anybody that has a history of an alcohol use disorder and it's coming into treatment. And certainly it's extremely important to make sure that you administer thiamine IM or IV before somebody gets IV fluids, particularly like a D5W, because if you get your D5W before you've been administered the thiamine, the dextrose can occupy, those receptors, not allow the thiamine to bind, and you can precipitate, a Wernicke's encephalopathy. So extremely important to remember that. There's different, protocols for alcohol withdrawal. The way that I was treated, in McLean was certainly, to not use like a standard protocol for everybody, but to rather use a symptom-triggered approach so that I could individualize the detox protocol to each person. Because there are some protocols, sort of, like a loading dose therapy protocol that will, give a patient, a diazepam or Ativan, in increasingly rapid doses until the point that they're seeming, apparently, drunk, from receiving the benzos, and then you start to taper them there. And I think you run the risk of being put in a situation where you give too much of a benzo too quickly out of too much of a fear that they're going to withdraw, and then you find yourself trying to, overcorrect. So I'm not a fan of loading dose therapy. I like the symptom-triggered approach because I can use my CWA scale to assess all of the symptoms of withdrawal and be periodically giving them their dose of lorazepam or of chlordiazepoxide, or Librium based on the symptoms that they're having, trying to keep my CWA scores low and below an 8, and trying to keep, my vital signs low as well, trying to keep, the heart rate below 100 and the diastolic, below, 100, or 120 for sure. Once the way that I was trained was that for the first 24 hours, you follow the symptom triggered approach and then see what that person's 24-hour requirements were in the first day. And then you use that as the standard to move along your taper over the subsequent, 3 to 5 days. So that's where, again, the CEWA scale, has become my best friend. And, as we speak right now, I'm partnering with a nurse, a colleague of mine, with a woman back home who's doing an in-home detox. And we've been in touch all night, and today, monitoring her alcohol withdrawal symptoms, because she wanted to do this, this detox, at home, making sure that we're dosing, very, very carefully. So this is really, literally my best friend at the time, in this moment in time. So the CEWA enables us to quantify the severity of withdrawal and chart progress over time. It's easy to administer, it takes less than 5 minutes, and it really doesn't require much medical knowledge. So essentially, on a scale of 0 to 7 on a Likert scale, you're going to be assessing, both subjectively and objectively, presence of nausea or vomiting and giving that a score, presence of tremors and giving that a score, presence of anxiety, agitation, paroxysmal sweats, orientation and clouding of sensorium, presence or absence of any tactile disturbances, presence or absence of any auditory disturbances, any visual disturbances, and presence or not of headache. Again, while monitoring vital signs. The goal, so if somebody scores less than 8 on the CEWA score, they're considered to be in minimal or mild alcohol withdrawal and may not require benzodiazepines or any other medications for the withdrawal process. 8 to 14 is considered moderate, and there probably medications would be indicated. A CEWA greater than 15 is severe, and possibly a sign that this person should be going inpatient, for detox. And somebody with a CEWA greater than 20 should probably be really close, if not inside of an ICU, for due to concerns and high risk of impending DTs. Again, this is a busy slide, with the protocols of dosing. Again, I'm not going to go into a lot of detail because it's going to vary depending on what hospital or program you're working at. But the overall goal is to again do the CEWA scores, monitor your scores, dose accordingly, and try to keep your patients, with the help of the medications, with low CEWA scores, under 8, heart rate under 100, and diastolic blood pressures less than 100 as well. And anything higher than that, certainly to consider an inpatient or even an ICU admission. Once you've calculated that first requirement in the first 24 hours, then you can start to taper by 15%, a day until the taper is complete. When using a long-acting benzodiazepine, I personally like and feel very comfortable using chlordiazepoxide or Librium. And I think my patients oftentimes feel that their detox is much more tolerable and smoother with something long-acting like Librium versus using Ativan, even though we said that in a med-surg kind of setting, it's easier, to Ativan or lorazepam. It's probably best to use, lorazepam because you can control your doses better. That being said, again, with Librium, it's long-acting. It helps for a more comfortable detox experience, and it has the property, which is that it has active metabolites that self-taper even after the last dose. So many of my patients find it comfortable, that even after they've completed their, 5-day detox protocol, and they get their last dose of chlordiazepoxide or Librium, that it stays in their system for about another 5 days, continuing to help smooth the withdrawal. There's certainly certain guidelines that can help, to give you an overall, sense of what somebody's withdrawal risk may be like. So certainly we could consider that somebody is a moderate drinker if they're drinking, a pint of alcohol a day, which is the equivalent of approximately 16 ounces. And here are the doses of what the overall requirements of chlorodiaxide epoxide or Librium might be for somebody that's a moderate drinker. Most of them would stabilize around 200 milligrams a day. Somebody that's a moderate drinker, again, the 1 pint or 60 ounces may stabilize, around 8 milligrams a day, 40 of diazepam or 240 of oxazepam. Heavy drinkers tend to be drinking, a quart or more of alcohol, and they will probably stabilize and require twice of the above doses of medications that we've talked about. Very heavy drinkers, that are drinking half a gallon of alcohol, even more a day, would probably end up requiring 4 times the above doses. And again, that for me is not somebody that I would feel comfortable doing a detox in an outpatient setting, but definitely more in an inpatient hospital setting. This again, a busy slide with the different doses and on what to give and how much. Certainly because we are prescribing benzodiazepines, it's always important to have parameters set for yourself also on when you would hold a dose, and certainly for respiratory rates, lower than 10 per minute, you should hold the benzo until they stabilize. So various protocols, as I recently shared with you, incorporate the use of anticonvulsants because of their role in reducing GABAergic activity. So, there's some studies in the literature, to support the use of carbamazepine and support, that with carbamazepine you have reduced rebound withdrawal and post-detox drinking. There's, some protocols that incorporate the use of gabapentin. When I was at Mayo Clinic, we used to prescribe, a lot of gabapentin, and it would help the detox process to go smoother. That being said, this day and age, where unfortunately there's so much misuse and abuse of gabapentin, it's not, a medication that I gravitate to with as much comfort as I did, years ago. And certainly be mindful that if you are using an anticonvulsant such as carbamazepine or divalproex, to be mindful of their hepatic risk or hematologic risk, and the importance of monitoring that also. In the end, anticonvulsants overall, like everything in life, have their pros and cons, or their advantages and disadvantages. Their advantages is that, with the exception of gabapentin, they tend to not have much of an abuse liability. And can help in protracted withdrawal. Some of the disadvantages is that most people have limited clinical experience. Some cause hematologic side effects, and some can contribute to liver toxicity.